Starting already. Dr. Amareshwar.
Ujjwal sir, good evening. Ujjwal sir, good evening. My voice is audible, sir?
Yeah, I can hear you. Ujjwal, can you hear me? I'm Dr. Prabhakar here. I'm raising my amp. Yes. I think he can hear.
पूजा लाइन है सर म्यूट लो सर मेरी किरण सर मेरे को शेयर वीडियो सर स्टार्ट करो शेयर सर सर ओके सर अरे सर
Yeah, now you can see. Yeah. Kiran, shall we begin? Ujjwal?
Yes, sir.
Okay. I think we are already around 15 minutes late. I think everybody is there. I welcome all of you. I welcome all of you for this today's webinar. This is being sponsored by this Sun Pharma, and the topic here for discussion is chronic small bowel diarrhea and approach to clinical diagnosis. For this, Dr. Ujjwal Gajula is going to speak. Dr. Ujjwal Gajula is young and upcoming gastroenterologist. He has completed his training from Chennai Apollo Hospital. After this, he has come here, and from last 8 months, he is in Hyderabad only. I and Ujjwal both are gastroenterologists working in Apollo Hyderabad. It's a pleasure, and I interact with him daily. He has got a very dynamic and aggressive approach in this gastroenterology. He has chosen this topic because this diarrhea is a very common problem. How it is evaluated, how we can practically approach it without going for high investigations. With these few words, I request Ujjwal to take up and then present his studies on this chronic small bowel diarrhea and approach to clinical diagnosis. Without going much into that one, it will be useful for all the practitioners, physicians who see it as a day-to-day problem, no doubt about it. But once there is a chronic diarrhea, how we are going to approach it? Acute, no problem. But once it is chronic, how we are going to approach, when you should investigate, what are the investigations that are there. Okay, over to Ujjwal. Please take over.
Thank you, sir. Thank you for your warm regards. And shall I start? Is it audible, sir?
Yeah, very clear. I don't know about audience.
Okay.
Everybody here? Hello? Yeah, I think you can carry on. Ujjwal.
Yes, sir.
Yeah.
Yes, sir. Good evening, respected seniors and my dear colleagues. So today's topic is about chronic small bowel diarrhea and approach to clinical diagnosis. Without wasting much time, I'll just go to the first slide. Yeah, today's agenda of my topic is about how to define chronic small bowel diarrhea and to classify them. And second thing is to approach, how to approach a patient with chronic small bowel diarrhea. And I have kept my few interesting case capsule along with these things. And so coming to definition of diarrhea. So there are various definitions in various textbooks, but as per Schlesinger, they mention that abnormal passage of loose or liquid stools or stools more than 3 times per day. Or if you can measure this volume of stool will be more than, if it is more than 200 grams per day, we call it as diarrhea. And so acute means less than 2 weeks. Persistent we usually don't use for adult, but there is a category in pediatric. They say that persistent is if it is more than 2 weeks. But for our chronic diarrhea, if it is diarrhea persistent more than 4 weeks, and if it is chronic, we have to define whether it is small bowel or large bowel. So how to differentiate between small bowel and large bowel diarrhea, I'll just explain in the next slide. So if you see a patient with chronic diarrhea for more than 4 weeks, we need to differentiate whether it is large bowel or small bowel type of diarrhea. So if you see this slide, if you have large amount of volume, we usually think of small bowel diarrhea, and large bowel diarrhea won't have the amount of food, stool will be lesser when compared to small bowel, because fluid absorption mostly takes place in the small bowel. And if you see blood, if it is usually large bowel diarrhea. And if you have tenesmus or rectal symptoms, it goes towards large bowel diarrhea. And mucus will be more seen in large bowel diarrhea. And if you find any fat in the stools, when some patients will complain of oily stools, that usually suggest small bowel diarrhea rather than large bowel. And presence of excess flatulence, that means absorption in the can cause excess flatulence, that usually suggests small bowel diarrhea. And if you find any patient with protein malabsorption, they usually come with pedal edema. That will happen when you have small bowel absorption problem rather than large bowel diarrhea. And presence of pain, mostly in the upper abdomen or periumbilical region, and that usually don't have any relation with passage of stools in small bowel type. And pain in large bowel usually in the hypogastrium, and that will usually decreases after passing stool. And if you find any pale color stools, that indicates some kind of small bowel malabsorption of fat, that suggests small bowel diarrhea. And odor usually offensive in small bowel, and vitamin deficiencies are frequent in small bowel diarrhea. This is the simple thing which can help you in differentiating between large bowel and small bowel diarrhea. So important things are amount of volume of diarrhea and presence of any protein and vitamin malabsorption will easily differentiate between small and large bowel diarrhea. And depending on the type of stool, we usually differentiate into 3 types of chronic diarrhea. one is watery, second is fatty, third is inflammatory diarrhea. So our topic of interest is mostly in watery and fatty diarrhea, because inflammatory diarrheas are like Crohn's disease and ulcerative colitis involves large intestine. So they usually present with blood in stools. So, but most of the small bowel diarrheas are watery or fatty, like it can be secretory or osmotic if it is watery, or in fatty diarrhea like with the pancreatic insufficiency and patient with malabsorption. In the later, they present with presence of oily stools. They usually is a symptom of small bowel. And if you want to differentiate between in small bowel diarrhea, there are 2 variants like watery and fatty diarrhea. So pain is a predominant feature in watery diarrhea, and it can be focal or diffuse. And pain usually associated with meals, and it usually associated with bloating and distension. And it can have non-specific symptoms such as fatigue and generalized malaise. But in case of fatty diarrhea, usually patient will complain of pale color stools with sticky in nature and difficult to flush when they go to washroom. And it is usually postprandial diarrhea. And when they when they stop the meals, they may not get this fatty diarrhea. Means diarrhea improves with fasting in fatty diarrhea. And they usually predominantly associate with weight loss with normal appetite. And most of the fatty diarrheas are due to malabsorption. And so in causes of small bowel chronic diarrhea, so we can differentiate like into intestinal causes and extra intestinal causes. In intestinal causes, first thing is sprue-like diarrhea. Sprue means they present with watery large volume diarrhea. So it's usually celiac disease, tropical sprue, collagenous sprue, and immunodeficiency related diarrheas. If it is non-sprue-like, they usually infectious like giardia, tuberculosis, and small intestinal bacterial overgrowth, and drug-induced diarrheas, and ischemic enteropathy, and autoimmune enteropathy, and HIV-related enteropathy, and Whipple's disease. All these things are most of the common causes which causes small bowel chronic diarrheas. And if you can see this picture, you can come from this is the lumen of the small intestine. So in which luminal causes usually like infectious causes such as parasites and small intestinal bacteria. When you have any absorption problems in the brush border, usually transport defects and brush border related enzyme deficiencies. And if you see at the enterocyte level, usually related to specific transport defects such as A beta lipoproteinemia and autoimmune enteropathy.
think Ujjwal, your slides are stopped. Can you hear me? Yeah.
Sorry.
Yeah.
Okay, sir.
Yeah, it has come on the screen. Now it's
Yes.
moving, no? Yeah.
Yes, yes. Yeah, if it is at the transmural level, it can involve Crohn's disease, eosinophilic gastroenteritis, and ileal resection or mesenteric ischemia. And submucosal level usually happens with tuberculosis and lymphoma. And if it is muscular res propria is involved, usually radiation related or amyloid deposits. And a nodal involvement usually happens with tuberculosis and lymphoma. So these are the basic things which causes small bowel diarrhea at the different various levels of the small intestine. And non-intestinal causes usually happens in cases of endocrine disorders, particularly with hyperthyroidism and diabetes, secondary to autonomic neuropathy, which can cause small bowel diarrhea, and congestive cardiac failure also, and which can cause secondary bacterial overgrowth. And so coming to approach to chronic diarrhea, the first thing in any patient with chronic any diarrhea patient, history is very, very important, and physical examination. So first, when you see any patient with chronic small bowel, please spend at least 15 minutes to take good history, in which we need to see whether it is acute or chronic, depending on the duration of symptoms, and see the pattern, whether it is continuous or intermittent. And third thing is, how is the stool characteristics? So just ask the patient whether it is any watery diarrhea or any presence of oily stools. And the third thing is any bloody diarrhea. So we can easily differentiate it with this thing. So we can come to a initial conclusion which type of diarrhea is. And at the same time, we need to ask travel history, what is the dietary history, recent, and drug history. These things are important because some of the drugs such as olmesartan and antibiotics can also cause chronic small bowel diarrhea. And the next thing is any sexual activity, abnormal sexual activity. We need to know why, because HIV/AIDS can cause small bowel diarrhea because of chronic parasitic infections. And if we need to ask whether he had any major small bowel resection to rule out any short bowel syndrome. And we need to ask about any radiation history, surgery, and any sometimes laxative abuse usually happens with anorexia nervosa or bulimia nervosa. Those patients, they come with diarrhea. We need to ask them the laxative history. And associated symptoms are important, like any abdominal pain, which can give an idea about any inflammatory pathology or infective or ischemic pathology. And to ask about the signs of malabsorption, we need to just ask about weight loss, which can indicate that any chronic malabsorption. And we have to ask underlying systemic diseases like diabetes, hyperthyroidism, HIV, and collagen vascular diseases, and immunoglobulin deficiency, and any background neoplasm. So after asking the history, just first thing is we need to have a quick physical examination. Why? Because small bowel diarrheas produce large amount of volume loss. We need to look for their nutritional status. Like first thing is fluid status, and the nutritional examination important to look for any signs of malnutrition like muscle wasting, and the same we need to see his oral cavity, and any signs of protein malabsorption leading to pedal edema and clubbing we need to see. And anemia is very important. So that can give you a quick idea about type of disease. and signs of vitamin deficiencies. And oral cavity is important to look for any ulcers, any cheilitis and gum bleeding and candida infection in case of HIV patients. And thyromegaly is very important to look for any features of hyperthyroidism, and we need to see for any neck nodes to rule out any tuberculosis, lymphoma and other things which can also cause chronic diarrhea. And clubbing, pigmentation and perianal area is important usually in patients with Crohn's disease and also any patients with HIV/AIDS patient. And these are the simple things when you see this patient with hyperpigmentation, we can see it's a patient of vitamin B12 deficiency. And recurrent aphthous ulcers that can give you an indirect clue of so many various diseases related to small bowel diarrhea. And coming to investigations, basic investigation, there are so many investigations which we usually do in patients with small bowel diarrhea, but I will give you a simple investigations later on. But these are the common tests which you usually prescribe in patients with chronic small bowel diarrhea. And CBP, we usually look for anemia. Stool examination is very important. We need to ask routine and special stains. Why special stains are important? Usually we ask modified AFB stain to look for any parasitic infections such as Cryptosporidia, Isospora and Cytospora. And anemia is very important, in which we need to work up for whether he has any B12 or iron deficiency. So, and these are malabsorption tests we usually ask for patients with tropical sprue, such as D-xylose test and fecal fat excretion to look for any stool fat content. And IgA TTG, we usually ask for patients to rule out celiac disease. Endoscopy and intestinal biopsy, duodenal biopsy is very important to rule out any patients of infective and inflammatory diarrheas. And CT, chest X-ray, CT angiography to rule out any tuberculosis or lymphoma. And HIV CD4 count is important for patients with chronic parasitic infections with immunodeficiency state. And second approach, we usually ask for non-intestinal causes. If you don't find anything, we usually ask for hyperthyroid features, so T3, T4, cortisol levels, immunoglobulin levels. And patients of neuroendocrine tumors also rarely they present with diarrhea, so we need to ask for serum gastrin, VIP levels and calcitonin levels in patients with hyperparathyroidism. And so in stool examination, when you ask, particularly in patient with chronic small bowel diarrhea, we should ask these basic things are important. First thing is color of the stools. It can give you indirect clue, like if patient has pale pale stools, that suggests some kind of fatty malabsorption. And if they have any red color stools, and that is bloody diarrhea, that gives an inflammatory diarrhea, inflammatory pathology. And electrolytes are important to know about whether it is a high osmolar or normal osmolar diarrhea. So to look for an osmotic gap, in which we usually see that stool electrolytes when compared with so if you have any high osmotic gap, they usually suggest some kind of laxative abuse or some kind of intolerance to any food, like lactose intolerance. All those things can be diagnosed with stool. And we have to ask for pH and FOBT to rule out any occult blood. And stool WBC important to tell whether there is any inflammation, to look for any pus cells. And stool fat is important to rule out any Sudan black stain, to look for number of fat globules. If it is more than 9 in a slide, is suggests that patient has fat malabsorption. And stool quantification also we do in patients with fat malabsorption. And special stains, as I told, for modified AFB, that will help you in differentiating between watery, fatty and inflammatory diarrheas. And this slide is when you have a watery diarrhea, so like patient came with small bowel diarrhea, we usually ask for fecal osmotic gap. If it is high, it is more than 125, that suggests some kind of osmotic kind of diarrhea. So if diarrhea improves with fasting, that we need to ask the diet history. So, and at the same time, hydrogen breath test So that will confirm lactose intolerance, and any intolerance means the food is not getting absorbed. So that will come in the stools. So that will be diagnosed when you have high osmotic gap, which improves with fasting. And if it doesn't improve, we need to exclude other diagnosis. And the second thing is, if you have a enormous stool osmotic gap, we need to suspect IBS or functional thing. Just we need to ask to them to have a diet modification, usually like low FODMAP diet. If diarrhea improves, we have a diagnosis of IBS. If doesn't improve, we should think of celiac panel. And if the patient have any IgA TTG positivity is there, that tells it the patient will have celiac disease. If it is negative, we should think of other diagnosis. And third thing is, if you have a low osmotic gap, that suggests secretory diarrhea. So in which we need to ask for other causes of secretory diarrhea. That means some infections, chronic infections. We need to have stool analysis, and we need to exclude any anatomic defects in the form of, we need to do CT enterography, upper GI and lower colon, and blood tests selectively for it to rule out any neuroendocrine tumors and other endocrine panel. So as we have so many investigations, it's very difficult to remember all these things. So I'll give a simplified approach to chronic diarrhea. So if a patient present with chronic small bowel, that means large volume stools, we just have a differentiation like whether patient has anemia or patient doesn't have anemia. So if you have a patient have diarrhea with anemia, so we will get some kind of differential diagnosis. If you don't have a patient have diarrhea without anemia, usually happens with some kind of functional things such as IBS, HIV, or drug-induced, and collagen colitis or microscopic colitis. And if you find patient with chronic diarrhea plus anemia, so we need to differentiate whether patient has which kind of anemia. First thing is whether it is iron deficiency or anemia of chronic disease or megaloblastic anemia. So simply, if the patient has chronic diarrhea with iron deficiency anemia, that means patient has duodenal malabsorption of iron. So that usually happens with celiac disease. Second thing, we should suspect any strongyloidosis if they have any infection, parasitic infection because of blood loss from the duodenum. And third possibility can be radiation colitis. And fourth thing, we usually think of right colon growths, especially in elderly patients more than 50 years. So because of blood loss. And second thing, if you have anemia with anemia of chronic disease, that is if the ferritin is high and iron is low, so we think of anemia of chronic disease. So this usually happens with chronic inflammatory disorders such as Crohn's, TB, and IPSID. And if the patient has B12 deficiency leading to hyperpigmentation, and they have MCV is high, so you usually think of ileal malabsorption. That usually happens with tropical sprue and small intestinal bacterial overgrowth. And so depending on if you catch this anemia, so it will be easier to diagnose you various disorders. So if you find any iron deficiency with the diarrhea, ask for serum iron, TIBC, ferritin to look for iron deficiency. And at the same time, so as I told you, celiac disease is the most common diagnosis with chronic diarrhea with anemia. So ask for IgA TTG level, that helps to rule out celiac disease. And if you don't find anything, ask for colonoscopy, that will give you CA right colon growth. So, and if you don't find that thing also, the duodenal biopsy, which is very important to rule out any parasitic infestation such as strongyloiditis or any cryptosporidia, isospora, all those things can be diagnosed with duodenal biopsy. And inflammatory bowel disease such as Crohn's disease can involve any area. So it can also present with iron deficiency if it involves upper intestine. And the second thing is, if you find chronic diarrhea with megaloblastic anemia, we should ask for B12, folate, and bone marrow. And so as we know that B12 absorption usually takes place in the ileum, and we have other things such as duodenum, we have R factor, all those things. So if you find any megaloblastic anemia, try to have ileal and duodenal biopsy, where we can get any features of any villus atrophy or crypt hypertrophy that suggests some kind of malabsorption, which can usually happen with tropical sprue. And if you won't find anything, so we have to see where you have a small ileal malabsorption can happen with Crohn's disease and also tuberculosis, because these the things are important, which involves a ileocecal region. So we have to do CT enterography and hydrogen breath test to look for any small intestinal bacterial overgrowth. So, and at the same time, we need to check for fecal fat and D-xylose test. This will tell you about fat and carbohydrate malabsorption. So if you find any patient with chronic diarrhea with B12 deficiency, think of tropical sprue, SIBO, and Crohn's and TB. And if you find anemia of chronic disease with chronic diarrhea, so that suggests some kind of inflammation, so which can be CT cross-sectional image 6 times per day for a first 4 months, and he lost 10 kgs of weight over a period of 4 months. And that suggests that some kind of small bowel diarrhea with malabsorption. Why? Because he lost his weight. So on examination, he had aphthous ulcers with glossitis. His hemoglobin was 12.4 and ESR was normal. So we had stool examination, which was normal, no ova, no cyst. And the LFT showed low albumin, which suggests some kind of protein malabsorption, but globulins are normal. So why I'm asking about globulins is we need to know whether he has any immune deficiencies. That will, globulin is very important. In autoimmune enteropathy, there is an entity, it will have, they have increased globulin. If they have low globulins, that suggests that some kind of immunodeficiency. And we have done serology for HIV, HBsAg, and HIV got negative. So ultrasound was not remarkable. So we went ahead for endoscopy and duodenal biopsy. So when I saw the endoscopy, which showed edematous mucosa with scalloping of duodenal mucosa, from which we have taken the biopsies from the second part of the duodenum. So here I'm just telling about the importance of endoscopy in patients with chronic diarrhea. Why? Because this is the major investigation tool in chronic small bowel diarrhea, which helps in biopsies, and at the same time, which gives in a visual appearance, may be helpful for your diagnosis. So when we did duodenal biopsy, so here you can see the arrow mark where you can see a lot of infiltrates and also eosinophils in the lamina propria, and there is lot of villus atrophy also you can see in this picture. And this picture, as you know, this is the textbook picture which we got in the biopsy, which showed some kind of owl-eye appearance and cytoplasmic inclusion bodies is suggestive of cytomegalovirus. So second thing, so interestingly, along with this CMV, this patient also had some oval structures which you are seeing in this arrow mark which I am showing. These are the oval round structures are seen just above the nucleus. So what we call it, in terms of pathology, they call it as a parasitophorous vacuoles in the supranuclear cytoplasm. These usually suggestive of cycloisospora infection. So his final diagnosis was he had a mixed infection of cyclospora plus cytomegalovirus, and he presented to us with the chronic diarrhea. But interestingly, we did the HIV and also immunoglobulin study. All those things were negative in him. So this was a rare finding in an immunocompetent host. So finding both cyclospora and CMV, so which one to treat is important in this case. So we have treated both the infections because we don't find any, we didn't find any literature to treat the in patients with immunocompetent. Immunocompetent we have seen mixed infection, but immunocompetent we didn't saw much. So we have given trimethoprim and sulfamethoxazole for 10 days, and also valganciclovir we have given for 21 days, as he is an immunocompetent person. So patient improved well with medications. So as we found these two infections, I just want to mention in patient these kind of chronic parasitic infection usually happens with HIV patients. So I just want to enlighten on HIV diarrhea. So diarrhea is present in 100% patients with AIDS and 50% in Western patients. But after significant introduction of this heart, so this HIV diarrhea prevalence is reduced. To say it as HIV related diarrhea, CD4 count should be less than 250. The most common infection is cryptosporidiasis, 60% in patients with HIV patient. Second, followed by cystoisospora, which is 9%. Diarrhea is usually painless but voluminous, and we need to differentiate because HIV related diarrhea and HIV enteropathy. So if you don't find out any infection like cryptosporidia or cystoisospora, so when all chronic parasitic infections are ruled out, we usually call it as HIV related enteropathy. So areas and HIV enteropathy. So common pathogens are cryptosporidia, cystoisospora and cycloisospora and microsporidia. So diagnosis will be confirmed by stool examination like a modified AFB or duodenal biopsy. So this is the patient with chronic diarrhea in HIV, where on duodenal biopsy you see the small dotted structures over the mucosa, which usually is confirmatory of cryptosporidium. So when you see the mucosa, if any parasite, when you see a rounded structure outside the mucosa, you should think of cryptosporidium. And if it is this small oval structure, if it is present above the supranuclear cytoplasm, we should think of cyclospora. So if this parasitic infection goes isospora. So when you find this cryptosporidia, your diagnosis is confirmed. The treatment is nitazoxanide plus ART. And when you see this duodenal biopsy, it's a patient of HIV. So you see this organism which is buried below this nucleus, and the size of the organism parasite is a little bit bigger. Almost five times methoxyl for stronger lidosis. So you see the organisms in duodenal biopsy, treatment will be ivermectin. And for patients with giardiasis, so when you see the flagellates above the mucosa, especially seen in patients with CVID, so that diagnosis will be confirmed in the histopathology, or you can say in the stool analysis itself. So treatment is metronidazole. So these are the common chronic infections in patients with HIV and immunodeficiency states. So I'll go to quickly go to second case. The patient of Mrs. A presented, 70-year-old female in Chennai, presented with loose stool since 3 months, weight loss since 2 months, and leg swelling since 1.5 months. So we asked for negative history of any like thyroid insufficiency. We asked for any surgical history, and at the same time diet history also we asked, and tropical screening also we asked. Everything was negative, but we got a catchy and she was taking some long-term antihypertensive called as olmesartan since 30 years. So on evaluation, her hemoglobin was 8.9 and ESR was normal, platelets were normal, stool analysis were normal, including modified AFB, and potassium was a little bit lower side because of diarrhea. LFT showed low protein, and thyroid and B12 workup was normal. Serum iron ferritin was on lower side. So we did an upper GI endoscopy which showed flattened duodenal folds, and the lower endoscopy showed some polyp in the segment, was nothing significant. So interestingly, that biopsy which we did on duodenum, which showed severe villus atrophy with increased lymphocyte and plasma cells in the lamina propria. And there is a subepithelial collagen deposition, usually happens with collagenous prune, which is focal, and there is some kind of apoptosis cells. and there is increased eosinophils in the duodenal biopsy. So, but we have screened for everything. Actually, we asked for cilia panel, tropical workup, and HIV. All those things were negative, but we couldn't find out any confirmatory cause for this patient. But when we saw the literature uh, for drug-induced diarrheas, they mentioned olmesartan is one of the cause for the olmesartan like in patients. So we withdraw olmesartan in the patient. The patient has so we at the end we came to a conclusion of olmesartan induced enteropathy in this patient. So once we stopped this medicine, patient was improved marginally after withdrawal of this drug. So I just need to mention about some about drug-induced diarrhea. So can happen with caffeine, what we call the Starbucks diarrhea, and thiophylline, and also antibiotics can cause like amoxicillin, azithromycin, and chemotherapeutic drugs can cause apoptotic diarrhea, and olmesartan can cause sprue-like features, and they present with chronic small bowel diarrhea if they take in long-term doses, and laxatives and pseudomembranous colitis. So when we saw the literature, they say that there is some kind of focal subepithelial collagen deposition can happen with olmesartan. So that's how we came to a diagnosis, and on withdrawal of drug, the patient has improved. So we can prove that the diarrhea might be because of that olmesartan. So in third case, he's a 25-year-old male from South India. Why I particularly mentioned South India, because there is some variation in type of diarrheas in South and North India. So usually in South India, we see tropical sprue is the most common cause for chronic diarrhea, especially in children. But in northern countries, northern India, they usually see celiac disease as the most common diarrhea. So this patient we presented with chronic intermittent diarrhea. On examination, hemoglobin was 6 and his MC was 104, and examination he has severe pallor and hyperpigmentation of hands and feet. And on a further evaluation, B12 was very low, and we did endoscopy and colonoscopy and ileoscopy for this patient. And duodenal biopsy, patient has crypt hyperplasia, you see, and villus atrophy. So this suggests some kind of inflammation is going on. There is a lot of lymphoplasmocytic infiltrate in this patient. And at the same time, ileum, you see the normal kind of inflammation in both in the ileum and also in and features of malabsorption, and the patient from the South India, and with we came to conclusion of tropical sprue in this patient. So actually there is no single test to diagnose a tropical sprue. First thing we can prove it is indirectly with the form of some kind of malabsorption test like D-xylose test, which proves 95% sensitivity and fecal fat more than 90 to 90%. So duodenal biopsy will show partial villus atrophy and increased intraepithelial lymphocytes that can give you a clue of some kind of tropical inflammation in the subepithelial region. And so third thing is response to tetracycline. So when you give rapid clinical response to antibiotics, that can give you indirect evidence that patient has tropical sprue. So they usually present with chronic diarrhea, megaloblastic anemia, and weight loss. And we usually define tropical sprue if they have symptomatic malabsorption of 2 or more unrelated nutrients like protein, fat, or carbohydrate, or micronutrients such as vitamin deficiencies. And patient should be from a resident or visitor to tropical countries, so below the Tropic of Cancer. And if you don't find any other cause to define this tropical sprue, that will complete the diagnosis of tropical sprue. And This is the most common cause of diarrhea and malabsorption syndrome in the tropics, and it is uncommon in children. And there are two variants. One is epidemic form and also sporadic form. And first thing is a response to tetracycline. They usually have a rapid response to tetracycline. So we need to give for long term for their HLA and some genetic association. And at the same time, they eat a lot of wheat when compared to South Indians. Like we usually eat a lot of rice. So that may be the reason we won't find that many cases of celiac disease, but they usually present with chronic diarrhea, iron deficiency anemia, and short stature, and some other extra intestinal features also seen in celiac disease. And in celiac disease, we usually screen for, ask for diet history is important. Why? Because they have diarrhea with wheat, rye, barley. So when you have a positive history, you need to ask for IgA TTG levels. If it is more than 10, it's confirmatory of celiac disease. If it is 2 to 10, that is suspicious of CD. So if it is suspicious, do a duodenal biopsy. That will tell you whether they have complete villus atrophy or and crypt hyperplasia. That will give you some kind of malabsorption related to CD. So this is a March grade 3C, in which you are not seeing nothing. And to summarize, diarrhea is a symptom, not a disease. You can see both infectious and non-infectious diseases needs to be considered depending on the clinical presentation. And tropical sprue is the most common cause of chronic diarrhea in adults in India, wherever you go, in North and South India. But celiac disease is more commonly seen in North India. And duodenal biopsy is very, very important in diagnostic or suggestive of many conditions. And we need to treat the patient specifically, not empirically. So you have to go through this basic format so that you will definitely get diagnosis in 95% of the patients. And with this, I'll conclude my topic. And thank you very much for listening to this topic. So I'll just ask Dr. Prabhakar sir to tell some few words regarding this topic.
Thank you very much, Dr. Ujjwal. That was an excellent presentation. You have specifically talked an approach to the physicians that is very, very important, because these are the ones who see these cases day in and day out. And more importantly, when a physician sees a case of diarrhea, most of them they are able to tackle on their own. But what is more important is there are certain situations when, after taking history and also examination, some of these cases still do persist. And these are the cases where they have to think more, and you have given a very nice approach on how to investigate with simple basic investigation, how to do it. The important question that I think probably the patient will ask is, up to what extent they should treat, and at what point a gastroenterologist is going to play a role. I think if you can just summarize, when the patient, the physicians should refer to a gastroenterologist for much better workup, or what are the signals that are there that this is no longer in the purview of just symptomatic treatment, but they should investigate very specifically. And
yes, sir. Yeah, sir. Simplistic approach is, once is, if they have diarrhea, if you have associated features of malabsorption, if they get some diagnosis in stool examination, so they can go ahead for their treatment, because a specific treatment will be available depending on the stool analysis. But most of the diagnosis won't be happen with the simplistic approach. So if they need any gastroenterology, usually happens when they need any duodenal biopsies. So first thing, so if you have any histological evidence for which we will come to a good role. So that can, so through endoscopically, we can give an idea through duodenal biopsies. So where we can see the pattern of histological features and all these parasitic infections. At the same time, if they have any tropical sprue and celiac sprue, all those things can better seen with histology. So for if they can give a idea if patient has any features of initial workup, they can do like so features iron panels they can do B12 assays and stool examination, basic things they can do. If they can't find out any conclusive evidence, I think we will come to a role which can help them in diagnosing these diarrheas. So what's your perspective, sir?
Yeah, that's what I am asking. See, I think you have given a right approach. Important thing is, I think there are lots of physicians who are there. Are there any questions you would like to ask?
Yeah.
Yeah. See, and one more thing also, just to continue the discussion, most of the physicians, what they say is they see most of it they will be having either diabetes or hypertension or any of this cardiovascular disease. And a patient with diabetes comes and they have these GI symptoms. And one of them that is there is chronic diarrhea. When I mean to say chronic diarrhea persisting for more than 4 weeks, and it is occurring also. So in these cases, we know there are lots and lots of causes that can cause diarrhea in a diabetic, starting with duration. For example, if the patient continues for a long time and it's not properly controlled, they develop what's called diabetic autoimmune neuropathy. When they develop this autoimmune neuropathy, one of the causes that can cause this diarrhea is small intestinal bacterial overgrowth. And there, the approach is once you make a diagnosis, antibiotics are sometimes approached. Sometimes there is also important thing, drugs themselves can cause this diarrhea. I've seen few cases, and what you mentioned here is olmesartan was one of the causes for chronic diarrhea. In our own experience, what we have seen is the patient is on long-term glycine, that is metformin. If they continue for years together, and had one case also where they evaluated for all causes of diarrhea, nothing was there. Then what, by taking history, they found the patient was on high dose of the metformin from last.
Alarming features. Otherwise, I usually label them as IBS and I'll tell them to have diet modification. But if you
to start with, I think history-wise, the pain is a predominant symptom of IBS.
Yeah.
If I'm right.
Yeah, because
you're right.
Yeah, 30% of patients may not present with pain, ma'am, because in an Indian study, yeah, they mentioned that 30% of Indian patients may not present with pain.
Okay, but some of the books say that pain is.
Yeah. I'd like to agree with you. See, once upon a time, irritable bowel syndrome that was there was made a diagnosis of exclusion. That is, you do all the investigations are normal. So it was sort of a waste bin diagnosis. You do evaluate for some problem, it is not there. Anemia is not there, weight loss is not there, blood loss is not there. Then automatically you come to the conclusion that this is an irritable bowel syndrome. But now it's more a diagnosis by a specific thing. We have got what are criteria. Starting now, the latest thing is Rome criteria. In the Rome criteria, we've got a very specific definition. Any patient presenting with this altered bowels, presenting with abdominal pain. Abdominal pain is one of the important components, along with alteration in the bowels. Alteration in the bowels is either it can be stool frequency will be less, that's constipation, or it can be diarrhea. Third one, consistency. Some of them will have loose stools, some of them will have mucus stools. So these two things that are there. So alteration in consistency and also consistent frequency, along with abdominal pain, is a must criteria for this Rome. And in what you pointed out, if there is no abdominal pain, some of these patients can have what's called functional diarrhea. Functional diarrhea is different from this IBS. So to make a positive diagnosis, abdominal pain, alteration stool habit, and it should persist for more than 4 weeks. So, and that too in a year, at least for a period of at least 4 to 6 weeks, it is a must. So chronicity is the important one. Frequency is important. Change in consistency is important, along with abdominal pain. Then only you make a positive diagnosis. And other evaluation, no anemia, no weight loss, no other malabsorptive syndrome. That's a must for this IBS.
Sir, one question asked in the chat, sir. When to suspect metformin-induced diarrhea, sir?
Yeah, first and foremost thing, see, I raised that point only. When to suspect metformin? See, for physicians, diabetes is very common because 30% of our population, adult population, they do have diabetes. When it is chronic, and some of these patients, diabetic patients, they can present with abdominal symptoms. The commonest symptom of diabetes is constipation. But there is a small subset of patients who have GI symptoms who develop this diarrhea. So when this diarrhea is nocturnal diarrhea, then we definitely suspect what is called autonomic neuropathy and small intestinal bacterial overgrowth. This is a very common manifestation. In these cases, we have got a definite diagnostic feature. I think you have mentioned about SIBO, how to make a diagnosis, carbon exhalation, that the response to antibiotics is very, very important. If there is no response, the patient continues to have this diabetes. In these cases, after excluding all other causes, and in the history you mentioned that drugs are very important. When you exclude all this and the large dose of this metformin, prior to that it was going on. Yeah, and when you stop this, automatically the diarrhea stops. So it is mostly not in the initial phases, we don't make a diagnosis. Only after excluding all other causes and drug history is taken, and metformin is one of the causes in the anti-hyperglycemic agents or diabetic drugs. Metformin can be made a diagnosis. It is more by exclusion rather than making a positive diagnosis.
Sir, one more question was asked.
Yeah,
How,
you can take, no problem.
how common intestinal infestations as a cause of chronic diarrhea, and what are the common parasites and empirical regimen for that?
I think you discussed that very well. No, you can take it up right now.
Yeah, see, intestinal infestations in immunocompetent patient is very less likely. So as I mentioned, it's a very rare diagnosis which we had in immunocompetent patient. But the patient who are having HIV with less than 250 CD4 count and common variable immunodeficiency, CVID, all those things are more prone for this common parasitic infestations. And especially I told with HIV AIDS in India, so the prevalence is very high. So what are the common parasites? Means Cryptosporidia is the most commonest one, 60% I mentioned, and after which Isospora and Cyclospora, and you have Giardia, which is also a commoner thing. So we can't give any empirical regimen because every organism has different response to different drug. So, but I will mention as a whole, like for Cryptosporia, you usually give nitazoxanide, and Cytoisospora, we usually give Bactrim DS, what we call as trimethoprim and sulfamethoxazole, double strength, twice daily. And at the same time, we need to give ART for all these patients because they have to improve their immune status. Because once we give these antibiotics, they will improve and again they will land up in these recurrent infections. So we have to improve the ART. And for Cyclospora also we give Bactrim DS only, that trimethoprim and sulfamethoxazole. And for Strongyloides, the treatment regimen is ivermectin, that is for 3 days period. And for HIV patient, we give an extended regimen. So we cannot give this empirical regimen depending on the thing. But if you want to judge and you think that it's a intestinal parasite, you can give a combination of nitazoxanide and trimethoprim and sulfamethoxazole. That usually works in a wide range of parasitic infestation.
Here I'd like to add one point. You are specifically mentioning HIV, add another category of patients which we see. Most of the patients also see. Renal transplant patients or CKD patients who are hemodialysis. This is also another subset you can put along with HIV because they are immunocompromised. So use that category also. In those cases, suspect these opportunity infections.
Yeah, see, cytomegalovirus infection also most common we see in post-renal transplant. So they usually very difficult to treat them. Why? Because it buries in the submucosa. So they usually give some long-term Valgan cyclophosphamide for an extended period. For immunocompetent, they say that 21 days. But immunocompromised, there are no guidelines actually. Improvement in immune status is one of the important treatment for CMV they tell usually. So that's all, sir. Questions.
That's all.
Good evening, Dr. Prabhakar, sir.
Good evening.
This is Dr. Shakuntala, Associate Professor of Medicine. I was your student also, sir.
Oh, nice meeting you.
Yeah, nice, sir. I have a 67-year-old female patient.
6 to 7 years.
67-year-old female patient who is a 67. Diabetic and hypertensive, who goes on a frequent pilgrimage to Kasi, Banaras, and she came to me with a complaint of chronic diarrhea. I treated her with multiple medications. It didn't subside. Then subsequently, I referred her to a gastroenterologist at Global Hospitals. So she was subjected to a colonoscopic biopsy, and she was found to have a Giardia infection, sir. Giardia.
Yes. Okay.
So she was put on nitazoxanide and then B12 and all this host of drugs. So, but still she continuously, she persists to have those symptoms, sir. Persistently, she's complaining of diarrhea. She still complains of the same symptoms. How do I go about in this case?
See, number one, when you say giardiasis, you've got a very specific organism. And the drug of choice here is simply metronidazole rather than other drug. And it
that is what I saw in the slides, sir, actually.
So metronidazole is still the drug of choice. And here, sometimes we do make a diagnosis by doing duodenal biopsy here, because there is one organism that is seen, and that will be seen in the mental, institutional patients and others. So first and foremost thing, just review the slides and give a course of metronidazole and see, number one. And because you said colonoscopy also was done, in 65-year-old lady, when is presenting with diarrhea, one of the differential diagnoses that we would like to think of is microscopic colitis also. So if a biopsy is taken from this colon, see for this any collagenous fluid that is acting, collagenous layer, or lymphocytic colitis. In these cases, the approach will be little different. I think Dr. Ujjwal has covered that, and the drugs that are there that are useful. Maybe you can really look into it, and then probably because of her age. And third factor that is there is, you said always occurs when she's traveling.
Yes.
Once you're traveling and you get this sort of picture, tropical stool is again in the top of our mind. So these three things again, just relook or review, then probably we can come to the right underlying pathogenesis. Then appropriate drugs can be given, and probably we can tackle it. What do you say, Ujjwal?
Yes,
you got any other approach to that?
No, absolutely. Whatever you said is correct. It's almost, I think you told in a crisp manner, and these three things are very important.
Just think about it, madam, because just review all these things. And long-standing, you said that is diabetes, no?
Yes,
are you thinking of small intestinal bacterial overgrowth also?
Sorry, sir?
SIBO, small intestinal bacterial overgrowth.
Small intestinal bacterial overload. Okay, sir. Okay, sir.
Overgrowth.
Overgrowth.
Yeah.
Okay,
so there also you can just consider. These are the differential. I mean, when you are saying a diabetic, all these things.
Yes.
Something is there sometimes, very commonly. One more thing, which I think I should like to highlight is, there is one entity called fecal incontinence.
Yes, sir.
And one of the approaches that are there is, these patients, when they have, it is difficult to differentiate fecal incontinence and from real chronic diarrhea. In fecal incontinence, if we do peritoneal examination, the tone of the external sphincter that is there, anal sphincter, is lost. There, because the patient is not able to control, they will be continuously soiling that, and they think it is diarrhea. So in a diabetic, always see the sensation, see the external sphincter tone, and rule out fecal incontinence in any elderly, that too a diabetic. And diabetic, I told the commonest complication is constipation. But the second common complication that we see in the elderly patient is loss of anal sphincter tone. When that occurs, usually fecal incontinence is one differential that you should keep in mind.
Okay. Thank you.
These are points that I think you should keep in mind. Not that it is there, but just as a differential.
Yeah.
Because in approach to chronic diarrhea also, fecal incontinence is one differential diagnosis that you should keep in mind.
Okay.
I think that is given in chronic, that is diarrhea syndrome.
Okay, sir. Thank you, sir.
Okay.
Thank you.
So, if there are no more questions on the chat box, that was an excellent presentation. I think we covered most of the topic. It's still vast and extensive, no doubt about that. But we have covered the most common problems, how to tackle them, and probably physicians who are listening, probably they will know, because they know how to tackle all this. They know it is irritable bowel syndrome or infective, or it is going beyond that, not responding. There's a time where they can take the help of the gastroenterologist and probably come to a reasonable. So it was excellent presentation. I think it is. So thank you very much for participating in this one. And I thank Sun Pharma also arranging that one. I thank Kiran for arranging this. So, and have a good day.
Okay, sir. Thank you, sir.
Thank you, sir. Thank you, Dr. Ujjwal.
Thank you, madam.
Thanks for the doctors for participating, sir. Special thanks to Ujjwal sir and Prabhakar sir for giving their valuable views. Once again, the big thanks to all of you and good night, sir. Thank you very much.
Thank you. Thank you very much. Okay. Good night.
Good night.